especially for this topic. Dr. Lakshmi Kumar. Dr. Lakshmi Kumar we share the same interest in anesthesia, that is liver transplant anesthesia. She is the professor and probably the best person to take this talk. Over to Lakshmi Kumar to start the meeting, please. Start her talk.
So, good afternoon, ladies and gentlemen. I'm going to speak today on a topic which doesn't really come in the regular postgraduate topics, portal hypertension and its implication for the anesthesiologist. The way I'm going to go about it is definition of portal hypertension and the pathophysiology leading to the development of portal hypertension, classification of portal hypertension and its measurement, and then the crux of this topic, the anesthetic management of a patient with portal hypertension, management of acute variceal hemorrhages and anesthesia for tips are also the key things which an anesthetist should know. And of course, we will summarize and conclude at the end of 30 odd minutes. Now, I'll come to the definition and pathophysiology of portal hypertension. So in the background of development of portal hypertension is the destruction of the normal structure of the hepatocytes. The normal hepatic architecture is destroyed with initial neutrophil inflammation, bridging fibrosis, and then this fibrosis actually causes a resistance to the normal passage of blood in the portal veins and the portal system. As you all can see in this figure, portal vein is formed by the union of the splenic and the superior mesenteric vein as it enters into the hilum with multiple branches, which will then go into each one of the hepatocytes where it forms an integral component of the acinus. So, the destruction of the normal hepatic parenchyma causes resistance to the forward flow of blood, resulting in an increase in pressure in the portal system, which is called as portal hypertension. Now, when we talk about portal hypertension, almost 90% it is synonymous with a background of cirrhosis. There are 10% where there are different causes, right? Some which may affect the liver directly and some that might not. In the picture that you're seeing is actually a schematic representation of how liver injury occurs. In this case, it shows with alcohol. Alcohol is a vasodilator, increases the gut permeability, allows the transmigration of gram-negative bacteria into the hepatocytes. Within the hepatocyte, it activates the dormant Kupffer cells and the stellate cells, and there is a release of an enormous amount of inflammatory mediators from the stellate cells, which contributes to destruction of its parenchyma. Now we know what is portal hypertension. When we talk about what pressures do you imply when you talk of portal hypertension, the normal portal pressures. Portal pressures are measured by a terminology that is called as a hepatic venous pressure gradient, which I will describe to you subsequently. Suffice for now to say that normal values are less than 5 millimeters of mercury. If the value is between 6 and 10, then it becomes a category that is called as clinically significant portal hypertension. And if it is more than 12 millimeters of mercury, it is portal hypertension with complications. Usually, this is the pressure at which spontaneous variceal hemorrhages can occur in a patient with cirrhosis. So in the background, you know that there is a different function of the hepatocytes. The hepatocytes in zone 1, which actually surround the portal triad, are rich in oxygen and do a lot of the oxidative functions as well as the metabolism of the liver. And as you move further, this reserve pool gets depleted and they're more vulnerable to hypoxia. The unique nature of the liver is that it can regenerate by mitosis, and this is why a donor, an adult, can donate nearly 70% of his liver and recover up to 90% of the native liver after removal. So now this picture is of a basic structure of the liver acinus. You can see that the portal, you have the portal vein here and you have the central vein, right? Central vein relating to the systemic and the portal to the portal. You have this vascular endothelium, which is lined by the endothelial cells, surrounding which you have, between this and the endothelial cells is a space of Dicey, which is normally occupied by the stellate cells, which I will discuss later. And then, of course, you have the hepatic endothelial cells, which has its unique function. Also among this is a Kupffer cells, which we saw previously is capable of developing an inflammatory response that can lead to changes. The normal, this animation cartoon of the picture of the hepatic acinus will show a normal space of Deci and the normal hepatic stellate cells, which looks like ramifications. But this is important because it collects the lymphatics that accumulate in the space and drains it into the central hepatic system. But see what happens to the alteration in the microvasculature. These stellate cells become bizarre and deposit excessive amounts of collagen in this, and it completely distorts the hepatic architecture, as you can see here. The normal hepatocytes and hepatocytes that are activated by injury activates the stellate cells and the Kupffer cells with an abnormal deposition of collagen, destroying the space of Deci. And this is actually the etiology, one of the etiologies in which a patient develops ascites with cirrhosis, because there is a failure of absorption in the lymphatic system and it actually transutes across the pressure gradient into the abdomen. Right? And this is how, incidentally, when you do laparoscopy, you may be able to pick up a cirrhotic liver. You can see not the normal smooth surface, but a nodular appearance that is consistent with cirrhosis. Once a patient gets portal hypertension, he manifests decompensation in several ways. One of them is variceal hemorrhage. Two is ascites. And then, of course, you can have encephalopathy, jaundice. So remember that the intensity of cirrhosis and jaundice absolutely have no connection. You can have a patient with very severe cirrhosis with bilirubins of just 1.5 and vice versa. Now I'll go to the second part of my talk. How do I classify and how do I measure the portal pressures? So there are several classifications. I'm putting across two. I hope it makes sense to you. Portal hypertension is classified as pre-hepatic, before the portal vein. That is, portal vein thrombosis, a splenic vein thrombosis, or congenital stenosis at that point. Hepatic, or within the structure of the liver. This is a structural alteration of the liver by cirrhosis, alcoholic liver disease, primary biliary cirrhosis, inflammatory disorders, as well as infective causes like schistosomiasis, which is another reason for the development of portal hypertension, they say, in the African subcontinent. And the post-hepatic is the part where there is a venous drainage from the liver. Portal flows to the liver. The post-hepatic is a portion of the vena cava and the venous drainage from the liver. You can have a Budd-Chiari syndrome. You can have constrictive pericarditis that can actually result in portal hypertension. IVC obstruction and constrictive pericarditis or a cor pulmonale has also been described as one of the causes. So you have pre-hepatic at the portal vein, hepatic within the liver, post-hepatic in the venous system. Another classification is as sinusoidal, pre-sinusoidal, and post-sinusoidal, right? So essentially, it is the hepatic part is called as a pre-sinusoidal, and it talks about the primary biliary cirrhosis and schistosomiasis. The pre-hepatic is a portal vein, splenic vein thrombosis, and the post-hepatic, as I've described, relates to the heart, constrictive pericarditis, Budd-Chiari, and webs in the IVC and other exotic causes. Now, I'll come to how do I measure the hepatic venous pressure gradient. It's not as simple as it sounds, and therefore we don't see it being performed very often. So essentially, you would need a catheterization, a cath lab, and the fluoroscopy services, right? Now, as I move my pointer, a balloon-tipped catheter is actually passed, like a Swan-Ganz catheter, is passed down one of the major veins that can lead to the right atrium. It can be the IJV, it can be the subclavian, or it can be the femoral vein. So you reach the right atrium, and from there, the catheter is directed forwards through the diaphragm into the inferior vena cava, and under fluoroscopic guidance is directed to enter into the hepatic vein, which drains the liver. So this is a retrograde direction. Right? Now, at the point where it reaches the terminal branches of the hepatic vein. So, as the catheter measures here, you measure the right atrial pressure. Here, you measure the IVC pressure. At this point number 2, it is called as a free hepatic venous pressure. And as you pass it distally, you wedge, like you would wedge for a Swan-Ganz catheter. That is called as the wedge hepatic venous pressure. Now, the wedge hepatic venous pressure, the hepatic venous pressure gradient is given by the difference of the wedged hepatic venous pressure and the free hepatic venous pressure. And that is a value that you use when you're talking about a patient with portal hypertension. So they say that if it is post-sinusoidal, that is in the vein, or within the sinusoidal, which is the liver, both the hepatic venous pressure, the portal pressure, and the hepatic venous pressure gradient are elevated, and by looking at the pressures, one may be able to diagnose the cause for the portal hypertension. So, hepatic venous pressure gradient is normal if it is 1 to 5. More than 6 millimeters of mercury, you call it as portal hypertension. If it is more than 10, it is clinically significant portal hypertension, and more than 12, there is a risk of bleeding from varices. So a compensated cirrhosis with portal pressures between 6 and 10 may actually not have varices, but the moment it crosses 10, there is a imminent, definitely there will be the development of varices and an imminent possibility of an unexpected variceal hemorrhages. And the decompensated cirrhosis is the other end of the spectrum with very high portal pressures, refractory ascites, jaundice, and hepatorenal syndrome. Now I'll come to the anesthesia. Management of a patient with portal hypertension, I'm just going to put it into perspective with a case. We had a 59-year-old gentleman who came with malaise and hematuria. He had had a TURP about 6 months earlier, which was actually done under subarachnoid block. But at this point, he showed a high-grade uroendothelial tumor from the right kidney and is scheduled for a laparoscopic nephrouretrectomy. He had a background of chronic liver disease, and when we looked at the cuts of the abdomen that was taken along with the evaluation of his renal mass, you can find that the liver is shrunken, there is ascites, and here you can see this cluster of grapes, which is esophageal varices, which means he has significant portal hypertension, and this is the other hallmark of portal hypertension, which is a splenomegaly. So when you look at a patient, it may not be clinically evident, and how do you identify it? Sometimes just by doing blood counts when you find thrombocytopenia and evaluate as to cause of why the platelets are so low. Occasionally they can have jaundice, they may have pediledema or ascites. So in this gentleman's investigation, you can see that the platelets are low. Fortunately, the renal functions were normal. Bilirubin is about borderline, but the albumin is low and the prothrombin timer, the INR is elevated, the APTT is elevated, and the fibrinogen is a little low. He was at this point in time on lacilactone, and by a classification assessment, he fitted into a category of child B cirrhosis. Right? So this is something that you all know, child's classification that looks at 5 variables. It has been criticized for not being objective because all these encephalopathy and ascites can sometimes be objective. It has been replaced by the MELD, which is far more objective and takes into consideration renal function, which is an important prognosticator of outcomes in patients with cirrhosis. So when most of us do the MELD calculation on an online calculator, this patient had a score of 16 with an estimated 3-month mortality of 6%, and he came into the child B classification. Now, can I manage anesthesia for him the way I would do for most other patients? Now, we'll begin with, can I actually make him fast, right? Is he a full stomach? If I give him a carbo load, which I've been recommended to do in any major surgery, will there be a risk of aspiration? I feel that question is still unanswered. And our initial evaluation, you can see in the second ultrasound picture of the gastric residual volume at induction. The volume is larger, but it does not necessarily translate into high volume of gastric aspirate or a risk of aspiration at the time of induction, right? So these are the CT images, and the reason I'm putting up the CT image is the fact that you see this bunch of worms picture here, and this represents portal hypertension with esophageal varices. One needs to be cautious before you recklessly insert the Ryle's tube multiple times, because there is a risk for imminent and torrential vascular Ryle's tube bleeding, and we once had to take a patient for emergency tips when he came for transplant due to a Ryle's tube bleed. Again, the same caution needs to be exercised if one were to insert a TEE probe, and the guidelines now recommend that the TEE probe should only be inserted in grade 1 or grade 2 varices. Ideally, the patient should have had endoscopy about 4 weeks prior to the procedure. Now, we all know about the hepatic blood flow and the factors that affect the hepatic blood flow. So in the case of portal hypertension, the portal system is full. It's just that it is not able to reach the liver. So the hepatic arterial buffer response and those things may not really play a role here. Now, when we give anesthesia, we use the agents which are known to have the shortest half-life and a non-organ dependent elimination. By the fitting the bill would be propofol, which is superior to thiopentone. However, etomidate and ketamine can be safely used. And the key goals that I would follow are to maintain the mean arterial pressure, because I believe any perturbations of the mean arterial pressure can result in compromise of the hepatic function and an ischemic hepatitis. Sevoflurane is what we commonly use, and Sevo, Iso can both be used safely, and so also desflurane, which is lesser available in some of the centers. Remifentanil, I'm told, has reached India, not yet reached my OR, so fentanyl is what we use. And now, regarding neuraxial blocks, a child A patient can even come for a hepatectomy, and we sometimes put an epidural if it is an open hepatectomy. When it goes to child B, the decision to do a neuraxial block will be based upon the risk and outcome. If he were to come for, say, a TURBT or a TURP, which is a surgery where you know that the spinal has significant advantages, or if the patient has multiple comorbidities, we would still put a spinal, right? So, but in child A, central neuraxial blockade can be given, child B very cautiously, and child C never. So what do you do then for pain? So you can use alternative transverse abdominal spleen blocks. IV lidocaine is used by some. I'm not very happy with this for abdominal surgery. You must avoid NSAIDs for the risk of renal dysfunction. Always titrate drugs when you use, because cirrhotics are supposed to have a lesser tolerance to inhalational agents, and neuromuscular monitoring and BIS can be used, right? Remember that the coagulation in patients with liver disease is altered. So it is not that because they have a platelets of 80,000, they are going to bleed. That is a key thing we should know. Although they have low platelets, they are compensated for by an elevated level of von Willebrand factor that aggregates them, and a lower level of the protease inhibitor ADAMTS13. Similarly, while you have low levels of coagulation factors, you simultaneously have decreased level of the naturally occurring anticoagulants, protein C and protein S. And while you have elevated levels of TPA, which is a fibrinolysis, which starts fibrinolysis, the substrate for starting fibrinolysis, plasminogen, is low. So this is called as a rebalanced coagulation. And if and when facilities exist, we would recommend that this is used in the context of viscoelastic tests, right? You all will be familiar, and I'm not going to go into details. To me, the Rotem appears to be superior to the TEC. It's more product specific, and a combination of FIPTEM and XTEM may perhaps give us a realistic estimate of the coagulation that is happening in the patient. This, again, the combination of either of the viscoelastic tests as compared to a static test will be able to tell you specifically the clot formation time, the time for the clot to form, the strength of the clot, and the specific factors, whether it's platelets or fibrinogen, which is contributing to a poor clot formation. Now, as I said, all volatile anesthetics can be used in the liver, but all of them can produce complications, as we have seen. Even with isoflurane, we have had a fulminant hepatitis. And here they have documented a periportal preservation and pericentral necrosis. So with sevoflurane also anecdotally has been shown to be associated with the transaminitis. Now, as we move on from open to a lap surgery, we move on to the question if an epidural is actually needed, and then you start looking at alternative like an erector spinae block. Today we have come to a situation that if you have a laparoscopic or a robotic surgery which is major like a hepatectomy, then we would use a bilateral erector spinae catheter, and it works very well. There is a large phenestrine incision for retrieval of the thing, and a catheter placed in the mid or lower thoracic and directed downwards works very well in the post-op period. Regarding hemodynamic monitoring, how intensive would one go? Well, most of the monitors today are connected to an arterial line and will give you the pulse pressure variation, and this may be useful to tell you the volume status of the patient, except when the venous system is clamped. Now, I'll come on to the second last of my discussion today, the management of acute variceal hemorrhage in a patient with portal hypertension. Now, portal pressures increase gradually and progressively. The pharmacological management of this is a non-selective beta blocker. Initially, propranolol was used extensively, and today we are seeing carvedilol. Now, the dose that is recommended is up to a point that the systolic blood pressure is about 90 millimeters of mercury. Now, we have described that the cardiovascular system in a cirrhotic is high volume, high cardiac output, hyperdynamic circulation, low systemic vascular resistance, and you're adding the problem of decreasing blood pressure and the cardiac responsiveness. So if a patient comes despite the pharmacological management and presents with an acute variceal hemorrhage in the ICU, management is what is recommended in most ICU textbooks, the airway, breathing, and circulation first. You will start an IV, 2 large IV access and start replacement. Now, I would use normal saline initially or half normal saline with bicarb because I am not sure about their renal function and I do not want hyperkalemia to be a complication. I would immediately take blood for grouping and cross-matching and arrange blood, FFP, cryoprecipitate, and platelets. I would put an arterial line for a bleeding cirrhotic who's unstable. The need for a central line would be based upon my expertise, the availability, and the need for noradrenaline. In my ICUs, most of them would receive a central line almost immediately. Monitoring urine output is important. A broad spectrum antibiotic is recommended to be started immediately. Now, the goal of this management is to do a variceal ligation endoscopically when the patient is stable. And regarding product transfusion, the recommendations are one moves towards a restrictive. That means you target a hemoglobin of about 7 grams rather than 9. And this has been shown to be associated with improved outcomes. Now, the key to the management of variceal hemorrhage is pharmacological infusions of a vasopressor, which is directed towards the splanchnic circulation, and in this you have octreotide, vasopressin, somatostatin, or terlipressin. So I think octreotide is used very often in my center. The dose is 50 microgram bolus, an infusion of 50 micrograms per hour. Vasopressin can also be used in infusions of 0.2 to 0.4 units per minute, and they say it should be combined with NTG to target a systolic blood pressure of 90. Somatostatin can also be used. And terlipressin, they say 2 milligrams IV for 4 hours till bleeding is controlled and 1 milligram every 4 hours to prevent rebleeding. Now, octreotide, somatostatin and terlipressin can be given for between 2 to 5 days, but the recommendation for vasopressin is only for 24 hours. In my experience, I would be very cautious when I'm using any of these agents because excessive use of these agents can precipitate visceral ischemia. And it's best, supposing you were using noradrenaline as a vasopressor, you need to be cautious when you're also using these agents because a combined action can worsen a visceral ischemia in these patients. I'll come to the last of my presentation, and this is the need for TIPS. So what is TIPS? TIPS is transjugular intrahepatic portosystemic shunting. So in a patient with portal hypertension, TIPS is something that will be discussed at some point in time in management. When is it indicated? If a patient with portal hypertension has refractory ascites or recurrent variceal hemorrhages. So this is when a TIPS is actually indicated. The relative indications for TIPS are a refractory hepatic hydrothorax, hepatic veno-occlusive disease, Budd-Chiari syndrome, hepatorenal, that's like a relative indication, gastric fundal ectasia, and portal hypertensive gastropathy. When do I contraindicate? When should we not do TIPS? The absolute contraindication is a tricuspid regurgitation or a congestive heart failure because TIPS is an intervention that will actually deploy the portal blood into the systemic circulation and it immediately causes an increase in the volume overload and can precipitate congestive cardiac failure. Now, pulmonary artery hypertension with a mean pulmonary artery pressure of more than 45, which is labeled as severe pulmonary artery hypertension, is the contraindication. And hepatic cysts, biliary obstructions, and sepsis are also absolute contraindications. Relative contraindications, of course, are a portal vein thrombosis, obstruction of the hepatic vein, thrombocytopenia, where the platelet counts are very low because the risk of hemorrhage can be overwhelming. In a malignancy where you might actually disseminate the basic malignancy, and moderate pulmonary hypertension is a relative contraindication. So here, what is done in TIPS is through a balloon, there is a catheter that is in the fluoroscopic lab. You place a catheter again through the internal jugular vein into the hepatic vein. and you pass it down to a point where it is approximate to a branch of the portal vein. Now, for this, you will need fluoroscopic and ultrasound guidance and needs the presence of a second radiological assistant to help the management. Now, from the anesthetist side, I will come to the management of anesthesia. And you also need immobility during the time they are creating the communication between the portal vein and the hepatic vein. The cutting edge of the catheter is used to create an axis between the hepatic vein and the portal vein. And a PTEFE covered nitinol graft is placed, as you can see in the picture, schematically here and radiologically here. So this decompresses the excessive pressures in the portal vein into the systemic veins and reduces the complications associated with portal hypertension. As an anesthetist, when you're asked to give anesthesia for a patient with TIPS, we need to look at the multi-systemic manifestation. The cardiovascular system, as I've already said, low SVR, high cardiac output, low blood pressure worsened by the additional use of beta blockers for this patient, and a chronotropic incompetence, which is inherent and again worsened by the beta blocker. A rebalanced coagulation, as I've discussed. So when possible, you should only transfuse based upon the viscoelastic tests and not by static tests of coagulation. Restrictive pulmonary function test, because there is a large volume ascites that is inherent. And what I have not mentioned here is a renal dysfunction. And these patients are so very fragile. As I said, renal morbidity is the worst portender of poor prognosis in patients with cirrhosis. And these patients may very quickly go into a hepatorenal syndrome because of an extreme splanchnic vasodilatation, as well as during the TIPS, the use of contrast, the use of anesthetic agents may push the patient into a renal failure that we need to be cautious about. So as an anesthetist, remember it is in a remote location anesthesia. So you have a huge C-arm, you have the radiologist with his ultrasound machines, there is a huge tray with the radiology equipment needing to perform the procedure, which is a high-profile procedure. You probably have to cross your legs across a branch of the C-arm to reach the head end of the patient when you have to. Arterial monitoring is something that I mandate all the time whenever they are doing TIPS. If the patient is unstable, which he is likely to be, then you will get a CVP access for the potential use of vasopressors. Remember, you may have to give the right IJV to the radiologist, and therefore you might need to look at alternate IV lines for the development of vasopressors. At our center, we prefer intubation and controlled ventilation. Again, anesthesia induction will go through all the risks that I mentioned earlier. The full stomach, the mean arterial pressure, choice of induction agents. I don't routinely do a rapid sequence induction, but if the patient were to have tense, large volume ascites or in hepatic encephalopathy, then I would do rapid sequence induction. Succinylcholine can be used if the potassium is not high. You only need to remember you need to wait for recovery from succinylcholine because pseudocholinesterase levels could be low and the actions of succinylcholine prolonged. Now, there are complications with any procedure, and TIPS can be associated with sudden torrential bleed if either the portal vein, the hepatic vein, or the capsule of the liver is perforated. Other complications are, of course, you can have biliary complications, which may be perhaps intermediate, besides the known complications associated with the procedure. Right? This is again a picture that is done, and you can see the thing and this is seen very finely. This is actually the TIPS that is inserted into the liver. So post-procedurally, it's not all over. You do need to shift the patient to a dedicated ICU with preferably access for liver transplant. 20% of the patients who've been treated with TIPS may develop encephalopathy. As I mentioned, the use of contrast could trigger contrast nephropathy, and the already labile renal status, AKI, can happen anytime. The one complication we need to pay attention to is the circulatory overload due to shunting of the portal blood. A hemolytic anemia resulting from the shearing of the blood cells across the shunt has been reported in the immediate post-operative period after shunt. So to conclude, I would say that portal hypertension is a point of manifestation of a more widespread disease and is associated with significant morbidity and mortality. Understanding the pathophysiology and the newer concepts on coagulation and systemic manifestations will improve management. TIPS is a treatment option for more severe decompensated cirrhosis with ascites or recurrent variceal hemorrhages. And multidisciplinary units and transplant affiliation will improve management. Thank you very much.
Thank you, Dr. Lakshmi. Very comprehensive. Am I audible? Am I audible? Hello. Am I audible? Hello, can you hear me?
Sir, audible.
Okay. It was a very complete
So we are not able to
presentation.
hear you.
Are you able to hear me?
Yeah, we can hear you actually.
Yeah.
I can hear you.
Yeah. Okay. Yeah, you're there. Yes. Continue, sir.
Hello, can you hear me?
Yeah. Yes, sir. Yes.
Okay. This was a very complete presentation of portal hypertension for postgraduates. She covered all three important questions. That is portal hypertension patient coming for incidental surgery, patient with esophageal variceal bleeding, and the patient for tips. Do we have any questions in the box?
No, sir. There are no questions from the delegates.
I think if there are no questions from the delegate, this is a difficult topic, difficult for the postgraduates. Usually they are not asked, but if they are asked these three questions, which are very well covered by Dr. Lakshmi. I think we can close the session. No
Thank you so
questions from
much.
me.
Yeah. Thank you so much, sir. And thank you, ma'am, for such wonderful presentation. It's a topic that usually people don't find much of a good literature on it. And your presentation would have definitely immensely helped all the PG students. I remember getting this particular portal hypertension as my case in DNB. I somehow sailed through, but maybe if I had this presentation, things would have been much more easier for me. So I'm sure it will benefit the other students.
Thank you.
Thank you so much, ma'am. So we'll move on to the next session, which is a short case presentation of for transurethral resection of the prostate.